This presentation will cover osteoporosis. I'm Bethany Von Hoff and I will be your presenter today. Osteoporosis is a skeletal disease characterized by low bone strength or low bone quality, predisposing someone to an increased risk of fracture. Osteoporosis is often associated with older people, and the complications affect people as they age. However, some people consider osteoporosis to be a pediatric disease because decisions that are made when you are younger, such as getting enough calcium and vitamin D and participating in weight-bearing activities when you are younger, are responsible for much of your bone health as you age. It gets harder to rebuild bone when you are older. 85 to 90% of your bone mass is acquired by age 18 in girls and by age 20 in boys, so most of your bone mass is built early in life. Your bone strength is typically measured by a proxy bone mineral density, or BMD. This measure of your BMD is compared to the average BMD of a 30-year-old Caucasian woman. If your BMD is 2.5 standard deviations below that, then you are diagnosed with osteoporosis. BMD is also used as a predictor of future fracture risk. It can be easy to think of your bones as being stagnant, hard structures, but this is far from the truth. Your bones are constantly going through a process of being built up and broken down, and these processes are essential for healthy bone development. If they did not go through this process, the bones would be very brittle. This process is referred to as bone remodeling or bone turnover. The breakdown of bone is specifically called bone resorption. The problem occurs when this breakdown and buildup become unbalanced, and there is more breakdown than buildup, and then there is net bone loss. As we introduced, bone mineral density is a predictor of future fracture risks, so with osteoporosis, we are testing bone mineral density to see if a patient is at risk for osteoporosis and at risk for a fracture. There are several parameters to assess bone health and fracture risk. The most common is the T-score. This is calculated after the patient's bone mineral density is done, and that bone mineral density is compared to the bone mineral density of a 30-year-old Caucasian woman using standard deviation. Standard deviation is a statistical measure of dispersion. It helps us understand how far away the patient's value is from the expected value. The more standard deviations away, the further the value is from the expected value. So if the T-score is more than 2.5 standard deviations below the normal, then the diagnosis of osteoporosis is given. If the T-score is greater than 1 below normal, 1 standard deviation below normal, then the diagnosis of osteopenia is given. The problem is that we don't fully understand what the risk is for someone with osteopenia. Some people with osteopenia will get fractures, and not everyone with osteoporosis will get fractures. So we know that someone with osteopenia has less than normal bone density, but we can't exactly say what that says about their risk. The other problem with this calculation is that everyone is being compared to a 30-year-old Caucasian woman, and not everyone is Caucasian, and osteoporosis can affect men, not just women. There are two categories of osteoporosis, and they differ on their risk and etiology. Primary osteoporosis occurs in all populations. It happens to everyone, because everyone starts with a certain bone mass and loses it over time. As we said, peak bone mass is between 18 and 25 years old, and then it starts to decline. While primary osteoporosis affects men, women, and all ethnicities, it is primarily seen in women after menopause and older age for men. Secondary osteoporosis is due to something else, a secondary cause. This is often medications, diseases, or other conditions. Medications can cause calcium to be wasted, so the body doesn't have the necessary building blocks that can weaken bones. Also, certain diseases such as hyperthyroidism or conditions that cause malabsorption, so the body isn't absorbing calcium or other essentials for bone health, can also lead to the secondary osteoporosis. This slide includes examples of secondary osteoporosis, including anticonvulsant therapy, hyperparathyroidism, or hypercalciuria, which means that too much calcium is being excreted in your urine. Osteoporosis is very common, with 1 out of every 2 Caucasian women will experience an osteoporotic fracture in her lifetime, and this goes up to 1 out of every 4 men, which is still pretty high. The most common location for fractures are hips, wrists, and spines. You may think that fracture is not a big deal, and many of you may have fractured or broken bones in the past. However, as you age, the complications associated with these fractures can be significant and traumatic, especially hip fractures. Hip fractures can be called the kiss of death because they can lead to a spiral of complications for patients. 20% of patients with a hip fracture will never live independently again. Once they have the hip fracture, they have trouble walking around or getting around, and this restricts their independence. Almost a quarter of patients who experience a hip fracture die within 1 year of the fracture. Additionally, there is a large economic cost associated with osteoporotic fractures. The cost just for treatment is over $19 billion annually, and this does not include the indirect costs associated with rehabilitation or care for no longer living independently. As we said before, hip fractures are very bad, and 24% of patients will die within 1 year, and 20% never live independently again. Osteoporosis can also cause fractures of the spine, and those are called vertebral fractures. These can also be associated with morbidity and mortality. Multiple fractures in the spine can lead to curving of the spine as it becomes more difficult to support the body weight. This can lead to posture changes where the patient is slumped over, and this is called kyphosis. This can restrict and limit mobility. Additionally, this can cause pain and can also cause organs to be compressed or pushed together in ways that they are not supposed to be. Risk factors for primary osteoporosis can be broken down into non-modifiable and modifiable risk factors. For non-modifiable risk factors, there are some things about yourself that you just cannot change. For example, if you are an older postmenopausal Caucasian woman, you can't change the fact that you're going to have some of those risk factors. Being postmenopausal is a risk factor because bone loss accelerates after menopause due to the decreased estrogen levels. However, there are modifiable risk factors that are things that both men and women can do to decrease the risk of osteoporosis. They can make sure they're getting enough calcium and vitamin D, as well as other vitamins including folic acid, B6, and B12. Patients should also stop smoking and limit alcohol intake. Drinking more than 2 alcoholic drinks per day is considered a risk factor for osteoporosis. Patients can also limit their caffeine intake and make sure that they are getting enough physical activity, especially weight-bearing activity. The bone mineral density and T-score are used to screen people for osteoporosis. All women 65 years and older should be screened regardless of other risk factors. Screening is done by something called a DEXA scan. Men 70 and older should also be screened, and as risk factors increase for women, they can be screened at a younger age. As we mentioned, we don't completely understand the value of screening or preventative therapy since the risk does not always correlate with who will have a fracture. It's hard to predict who will have a fracture even knowing their BMD and risk scores. Again, there are non-drug measures that everyone can do to reduce the risk of fractures and maintain healthy bones. It's important to make sure that your body has the building blocks that it needs. This includes adequate intake of calcium and vitamin D. Vitamin D helps the body absorb the calcium. More evidence is also showing that the B vitamins are essential in the cross-linkages in the bones that help give the bones strength. Weight-bearing activities are ones in which the body is responsible for, you guessed it, bearing its own weight, or supporting the weight of its own body. So this includes things like walking, aerobics, and gardening. So you're on your feet and your body is bearing its own weight. So anything where your body is responsible for supporting its own weight. So things like swimming, which can be a great exercise, is not weight bearing. It's recommended to get 30 minutes of weight bearing activity at least 3 times a week to reduce hip fractures. Exercise in general is also helpful because it can improve posture, balance, and strength, and stability, which all help reduce the risk of falls. Falls are often how the fractures occur. Fall prevention is important and includes things like correcting vision, monitoring medications that can lead to falls or dizziness, improving home safety, such as removing rugs that can be tripped on, having good lighting, and using assist devices throughout the house, such as a bar in the shower, that can all help prevent falls and fractures. We've been stressing the point that you need to make sure you're getting the right amount of calcium, so we'll look at how much calcium you should be getting. The recommended dietary allowance of calcium, as you can see on the chart, is based on age and gender. For adolescents, the RDA is 1,300 milligrams. This bumps down to 1,000 milligrams for women up to 50 and men up to 70. Then it goes back up to 1,200 milligrams for women over 51 and men over 71. The RDA includes calcium from food and from supplements. When you're looking at over-the-counter calcium, you want to make sure that you are looking at the elemental calcium because that's what the RDA is measuring. You cannot buy just plain calcium. It's always linked to a salt like calcium carbonate or calcium citrate. So you have to look at what the elemental calcium is on the label. Calcium carbonate is often preferred because it can be cheaper and you often don't have to take as many tablets. However, calcium citrate is often recommended for elderly patients or patients who may have low stomach acid because the calcium citrate is more easily absorbed even in an environment without much stomach acid. It is important to know that there can be too much of a good thing and that taking too much calcium may increase the risk of kidney stones and can increase cardiovascular risk if the patient is not also taking vitamin D. Food is generally considered the preferred source of calcium. Food rich in calcium also contain other healthy nutrients. Milk and yogurt generally contain about 300 milligrams of calcium per cup, which is a great way to get calcium in the diet. If you do not like or cannot eat dairy, there are other ways to get calcium fortified foods, such as orange juice, soy milk, breakfast bars, and cereals. All of these fortified foods can provide comparable amounts of calcium. Additionally, foods like almonds, broccoli, salmon, sardines, and beans can all provide a good source of calcium as well. People may be able to get the RDA just through their foods, and then you would only need to supplement when you cannot incorporate enough calcium through your regular diet. Vitamin D is very important for bones, but it is also important for immune functions and other functions. There's a recommended dietary allowance for vitamin D just like there was for calcium. This is determined by the Institute of Medicine. Vitamin D is measured in international units rather than milligrams like calcium was. You can see that for individuals less than 70 years old, the RDA is 600 international units, and that over 70 years old, this goes up to 800 international units. Vitamin D is one of the 4 fat-soluble vitamins, meaning that your body stores excess in your fat. Other vitamins, like vitamin C that are water-soluble, your body flushes out the excess that it does not need or cannot use at that time. This is important to know because if you work in a pharmacy or if you talk to someone who takes vitamin D, you may find that some people take small daily doses to supplement or some people take very large weekly doses to supplement. Since the excess can get stored in your body, it's okay to take the large doses at once when it is prescribed that way. While it is difficult to overdose on vitamin D, there is a recommended upper limit set for adults and children over 9 years old, and that is 4,000 international units daily. You will see sometimes people go over this if they are being monitored and their vitamin D level is being tracked by their provider. The body is able to produce its own vitamin D. For younger and fair-skinned people, they can make enough vitamin D in about 15 minutes of direct sun exposure, so the body is pretty efficient. The ability to produce vitamin D declines as we age, and also if you're using sunscreen, your body is not able to produce the vitamin D because it blocks the UV rays that are necessary for synthesis. You can also find vitamin D fortified foods such as milk and orange juice, but this is usually relatively small amounts, like 100 international units per serving. There are not many foods that naturally contain vitamin D. Like we said, our bodies can synthesize vitamin D from the sun, but it requires the sun in certain UV rays. If we live above 37 degrees of latitude, as seen as the darker gray on this map, we do not get enough direct sunlight year-round to synthesize vitamin D, especially November to February. Even on the sunny winter days, the angle of the sun is not enough, not to mention that most of your skin is probably covered up with jackets and scarves anyways. Because there's more and more documentation of vitamin D deficiency in the northern states, it's becoming more common to check vitamin D levels and replace the deficiencies. Even in the summer when we have more direct sunlight, we often and should be wearing sunscreen, which also inhibits the natural synthesis of vitamin D. So who else is at risk of being deficient? As age increases, your risk for being deficient increases. As we said, anyone living above 37 degrees latitude is at risk and could benefit from supplementation. This is especially true if you have darker complexion. People with darker complexion have a more difficult time synthesizing the vitamin D and need 3 times more 3 times more time in the sun as someone with light complexion. So if we said it's about 15 minutes is enough to synthesize, someone with darker complexion would need about 45 minutes in the sun. Sunscreen also filters out UVB light, which is the one responsible for making the vitamin D. Sunscreen is good for skin cancer protection, but it also diminishes the body's ability to make vitamin D. Also, anyone that has conditions that makes it hard to absorb nutrients, they're likely to need additional vitamin D supplementation. Breast milk does not contain significant amounts of vitamin D, so infants who are breastfed should get a vitamin D supplement. Additionally, infants are usually kept out of sunlight or use sunscreen, so they're not producing any on their own. Formula, though, is usually fortified with vitamin D. It's generally very difficult to get enough vitamin D from food alone. So remember that the RDA for individuals less than 70 years old is 60 international units a day. So that'd be about 6 glasses of milk a day or a lot of salmon every day. As you can see from this chart, the foods that contain vitamin D do not contain very many international units per serving. It's important to know that not all vitamin D supplements are the same. Vitamin D3 is the recommended supplement. It is more potent. Vitamin D2 is about a third of the potency of vitamin D3. Vitamin D2 is okay to take, but you just have to take more of it to get the same efficacy, and both forms are found over the counter. Now let's move into the drug therapy for osteoporosis. Candidates for drug therapy are patients with osteoporosis or patients who are at high risk for fractures. In general, this includes postmenopausal women and men older than 50. Candidates for drug therapy are women who already have osteoporosis or women who have already had a fracture or a BMD score below -2.5. Women with osteopenia can also be candidates if they have other risk factors, or women who are experiencing rapidly decreasing bone mineral density even after implementing the lifestyle changes we have talked about. The first-line therapy for treatment and prevention of hip and vertebral fractions are bisphosphonates. An example of the brand name is Fosamax and the generic is alendronate. The mechanism of action for these medications is that they inhibit the osteoclast activity. Osteoclasts are responsible for the bone breakdown. That's the resorption process that we talked about earlier. In osteoporosis, the balance is off and more bone is broken down than built up. Bisphosphonates interfere with that process and try to inhibit the breakdown of bone. They reduce the incidence of spine and hip fracture by about 50% over 3 years in patients with a previous fracture. There are many different bisphosphonates available. Some are dosed daily, weekly, monthly, or even yearly by an IV injection. The side effects for bisphosphonates are primarily GI side effects, things like nausea or acid reflux. When you take a bisphosphonate, you must take it with a full glass of water and remain upright for 30 minutes after taking it. The full glass of water prevents the tablet from getting stuck in the esophagus. The staying upright prevents the medication from refluxing back up into the esophagus. The medication is very irritating to the esophagus and the lining. You do not want the tablet or the contents of the medication refluxing back up into the esophagus or getting stuck there. This medication can cause erosion to the esophagus and there can be serious adverse events. This medication is really only able to be absorbed on an empty stomach. Even a small amount of food in the stomach can turn the absorption to near zero. This means that the patient is not only wasting money on the medication that won't work, but they also are not getting any benefit or protection from the medication. So patients are instructed to take it when they first wake up 30 minutes before any other food or medications. The second-line therapy is selective estrogen receptor modulators, or SERMs. An example is raloxifene or Evista. Evista acts like estrogen on some receptor sites and acts like an anti-estrogen on other receptor sites. On the bone, it acts like estrogen, and as we talked about, estrogen minimizes bone loss. These medications can also be used to help prevent breast cancer. However, Evista also carries some of the other risk factors associated with estrogen, such as thrombosis or clots in the lungs and legs. Evista can also cause hot flashes, since at some receptors in the vasculature, it is acting as an anti-estrogen. Evista has efficacy in reducing vertebral fractures, but it has shown no effect on hip fractures. It can reduce vertebral fractures by 30% in patients with a prior history of a fracture and by 55% in patients with no prior history of fracture. The next option is calcitonin, which goes by the brand name Miacalcin. Calcitonin is a naturally occurring substance in our body. However, this medication is made from a recombinant version of calcitonin found in salmon. This medication is administered as a nasal spray. It works by inhibiting osteoclasts. It has very few drug interactions and is generally quite safe. It is only indicated, though, for the treatment of osteoporosis, not prevention. It has also only shown efficacy in lowering vertebral fractures and has no effect on hip fractures. The most common side effect with this medication is just the nasal irritation from the spray, and epistaxis means bloody nose. So just as a reminder, the bisphosphonates are used for treatment and prevention of both hip and vertebral fractures. Evista can be used for treatment and prevention, but has no effect on hip fractures. And now calcitonin is only used for treatment and has no effect on hip fractures. Another option is Forteo or teriparatide. This is a recombinant parathyroid hormone found in our body. This drug stimulates new bone formation. Forteo can be a very effective medication, but it is reserved for the highest risk patients, those patients who have osteoporosis who have not responded to other therapies or have severe osteoporosis with high risk factor. Forteo has a risk of developing osteosarcoma, which is a bone cancer. This has been seen in many animal studies, and this drug now has a black box warning about osteosarcoma. Because of this risk, it's contraindicated in patient populations who also have an increased risk for osteosarcoma, including children, adolescents, and those with Paget's disease. Before 2002, estrogen by itself was sometimes used to prevent and treat osteoporosis in women. It was very effective. However, there was a study called the Women's Health Initiative that had to be stopped early because women who were randomized to receive estrogen were experiencing higher rates of heart attack and strokes than women who were taking a placebo. Now people recommend against the use of estrogen for osteoporosis. However, some women will still take estrogen for other reasons, such as low dose short term for menopausal symptoms. Estrogen was shown, however, to be effective in reducing both vertebral and hip fractures. It is important to follow up with the bone mineral density to make sure that it is improving or at least not getting worse. You typically would do the DEXA scan every 2 years, but you're also monitoring more regularly for things like incidence of fractures, adherence to medication, and making sure that the patient is actually taking it appropriately, like the bisphosphonates in the food. You also want to make sure that the patient is still getting the proper dietary or supplemental intake of nutrients. You also want to monitor for side effects and quality of life concerns. So in summary, all patients should be told about the importance of nutrition for treating and prevention of osteoporosis. Remember that some people consider osteoporosis to be a pediatric disease, so starting education about proper bone health early is important. The damage done when you were younger affects you when you are older. It is important to reduce risk factors, and just remember that bisphosphonates are the first line of drug therapy.